So this conversation is going to be facilitated by Paula Kruger. So Paula is the Chief Executive Officer of Media Diversity Australia. She's got an astonishing amount of experience across Australia and Southeast Asia over more than 30 years. Previously, Paula was Managing Director of the Sydney radio station 2SER, that many of you will know, where her leadership helped to grow the audience and revitalised volunteers involved with the organisation as well. Before then, Paul has also had a long media career working in management, editorial and journalistic on-air roles in Sydney, Canberra and Perth. Does that sound right to you, Paul? Yeah. And Paul is really passionate about ensuring Australia's media reflects rich cultural and socioeconomic diversity. And her life has celebrated this diversity and she takes great pride in her Fijian and Australian heritage. So thanks very much, Paul.
Thanks so much, Ben. And yes, I'm very much here as a communications person, and I just want to say how well everyone has done as far as communications goes. When earlier, when there was the flag raised that this is a sector that does love their jargon and acronyms, I kind of had this little knot in my stomach that twisted. But it has been a surprisingly, delightfully jargon-free zone, which is great because it means that it invites more people to the conversation, which seems to me is what today is all about. I'm also proudly the third woman in red. This hasn't been an intentional plant by Lifeblood, but if you typo, Lifeblood needs you right now, so make an appointment. But we're just going to go through the purpose of today's discussion, and there's a lot that we'd like to achieve in the next hour because we are not going to miss that lunch deadline. But the purpose of today's discussion is to really talk about community health navigators as far as what should their focus be, what should the scope be, what's working, what's not working. Hopefully we'll also have time to get your questions in as well. But you know, we've got 5 amazing experts here. So I'm just going to firstly introduce you by name, but then I'll get you to do your own bio. So, you know, in about 3 or 4 sentences, just tell us a little bit about the relevance of your experience to the conversation that we're going to have today. And so I'm going to start with you, Dr. Shabush Kandi Mistry, who is the lecturer at the School of Population Health and Health at the University of New South Wales here in Sydney.
Thanks, Paula. This is Sabuz. As mentioned, I am a lecturer at the School of Population Health, and my research was basically based on healthcare navigations and exploring the feasibility and acceptability of involving community health workers as community health navigators to improving access to health and social care services among the people from the culturally and linguistically diverse backgrounds in primary care settings. And this is one of the first research conducted in primary care setting in Australia, that which I did in my PhD work. And then we got additional fundings to work on this and still continue working in this space. Thank you.
And next we have Sharon Parker, who's a project manager at International Centre for Future Health Systems. Welcome along, Sharon. Tell us a bit about yourself.
Thank you. Yes, I'm not an expert by any stretch of the imagination, but I have over the last couple of years been working with a great group at RPA, and we've been looking at using community health navigators to help people who have chronic disease and who are transitioning from their care in the hospital back to their home.
Thank you so much, Sharon. And next is Dr. Anthony Brown, who is the CEO of Consumers New South Wales, so really bringing that consumer's perspective here today.
Thank you. And I'm one of the co-investigators in the project that Sharon was talking about, brought together by the wonderful Mark and Liz Harris. And I suppose what's really important to us from Health Consumers New South Wales, we're the peak body for patients and carers and people who use health services in their organisations, is the number of times we hear about people's fragmented experiences of care. And really wanted to, I suppose, have a better understanding of how navigation could be one way to help sort of integrate people's experiences there.
That's great. Thank you, Anthony. And next we have Professor Doolan Noble, who is the Director of the University Department of Rural Health at Curtin University in WA. Welcome along.
Thank you, and I'd just like to say in Kalgoorlie as well.
Absolutely. Sorry, Kalgoorlie, my old hometown.
So, all right, we'll talk later. So, yeah, in a previous life, I was a clinical manager at the West Coast PHO in New Zealand, so that's the west coast of the South Island, and did a bit of research which suggested that maybe navigators would be really useful. So back in 2006, we established a team of 4 navigators, and I'm very proud to say that at this stage, 3 of those 4 navigators are still in place, emphasising the benefit of choosing the right person, but choosing people from the community. So yeah, it's really key. Thank you.
Thank you. And at the end there, we have Luann Blunden, who is the Executive Director of Clinical Services Integration and Population Health. And Luann, tell us a little bit about your experience.
My experience, well, it's been a experience with community health navigators has been fairly recent. So really, it's just been the past 10 years. This is my 46th year in health. And I started in the acute system, not a nurse, a physio and a radiographer, but traversed that acute system where I really ignored the community health system and what was happening in the community. And back then, you didn't really discuss the community to that degree. It was all about acute. Sometimes some people are saying it hasn't changed much, but it has. So where I started with the district, it was under the former CE, Dr. Teresa Anderson, who formed the Clinical Services Integration and Population Health Directorate. And I think it was the first of its kind amongst the LHDs. And I know there's a number of people here today that have now a similar role, because it's come to the attention of many of the LHDs that we've got to get services working closer together. And as we've all said, to break down silos, but to get that community and acute interface much closer together, and think about how we can do things differently, as Susan, the Secretary, said this morning, but also take those opportunities of really addressing equity and what we're really here for. The Health Equity Unit, a shout out for the Health Equity Research Development Unit, which started with us, Liz and Mark, in 2015. I remember cracking a bottle of champagne one night when we formed the name of the Health Equity Unit. And that has been really a catalyst for us, really concentrating on very vulnerable people within our LHD, but also recognising the pockets, the need with the public health system to address public housing. And we've got Counterpoint, Jeff. He was here as well, and he and many of our partners, the PHN and also our NGOs, housing, DCJ, have all been a catalyst for us really addressing and for making us focus on that vulnerability and new ways of doing work.
And while you've got the microphone there, we might hit you with the first question is, what should the focus be, for the community health navigators, in your view, based on your experience?
I think we've heard this morning it was about vulnerability, so we really are concentrating on vulnerable pockets of our population. Much of that started pre-COVID, but was highlighted during COVID as well. But it's that public housing area where we have a lot of towers in our LHD. Many of you would know Waterloo Towers, the Redfern Towers. So those people that are very vulnerable, not taking away from our previous speaker who spoke about that short-term visit to a hospital where you need assistance when you go home, because originally a lot of that community health navigators, when we started it, we started thinking about extend workers back in 2015, where Liz and Mark were involved in that as well, and that was a pilot, but it was also addressing people that were living alone, returning home, maybe confused about their medications, but we as a health system weren't following them up. Sometimes people got a nurse visit within 48 hours or longer, But it was that initial investment of thinking into how do we, as like a family member that many of these people don't have to return home to, what can we do to assist those people when they return home immediately, get them to a GP, look at how they're taking their medication. And that was a non-medical worker. And so that was piloted, and that led into the NHMRC grant, didn't it, Mark, that we received to have a look at the roles of the community health network navigators in terms of chronic care and aged care. Getting back to the other, we're concentrating on vulnerability, so mental health, aged care. They're also used in areas, we're thinking about intellectual disability, which was raised this morning as well, opportunities there. I think I've mentioned mental health, have I? So we've got peer workers, we've got the Aboriginal health workers. So I'm not going to go into everything that's been said this morning. We have actually within our districts, within the LHDs. But I think it's trying to think of what will be the priority. And I think with government, it's getting a health prevention, health promotion message, as Justice Beasley had said in his report. If you haven't read it, I recommend you read the part on primary and community health. How it's not just the role of GPs and NGOs and others. As Jeff said, it's all of our role to protect population and the health of the population. So I think it is that vulnerability and working out who is vulnerable and how we best intervene or assist.
Shabush, based on your experience, what do you think should be the area of priority? Do you agree there that we're looking at health prevention, health promotion?
I will probably start from where Luan, you left, is the prevention. So as we already worked in improving access to healthcare services for already diagnosed and cases, and where we have placed navigators in the general practice. And as Professor Patricia and Professor Michael also mentioned in previous talk, that we need to explore for avenues where navigators can be used in different capacities. And I was looking into yesterday of some of the New South Wales policies and strategies in prevention as well. And here also the care integration is an important aspect that has been highlighted. And recently, last month, I visited Canada, and I have seen how community health navigators has been effectively used in prevention aspects, especially among the South Asian diaspora. I have seen they have a very famous program called South Asian Diabetes Prevention Program, SATPP, and they have absolutely amazingly used community health navigators in the preventive care. So it's like community health navigators in the community. So I think alongside our current initiatives of involving community navigators placed in primary care, we need to have the community navigator placed in the community as well, and doing health promotion, because we are we are having primary cares, but not very focused on prevention. Preventive care, public health, not focused on the prevention. Who is going to do this? It should be coming from the community, and community health navigators can do this health promotion, education, and screening for risk factors for particular health, for example, diabetes, and then with navigation in relation to the preventive care to the primary care. So I think this is another important avenues that where navigators need to be involved.
Great. If we can jump over to you, Fiona, and what do you think should be the priorities here? I'm trying to see if we're getting any common ground, but it's a complicated thing.
Look, I think there's a desire to quite often give the health navigator a defined description in their role. And I understand that because it helps with their identity, and it kind of stops that concern from others that there's going to be scope creep. But I also think we're missing an opportunity, because health navigators can do something that many of us can't. They can get out into the patient's home. They can see the living conditions. So if you make their role just about improving access, then you miss an opportunity for them to be involved in health prevention. So, you know, really, in my experience, back in 2007, we established those. At the time, they were just for cancer navigation, but after they did so well in that, we involved them into other chronic conditions, and now they look after the most complex in the community, so with physical but also mental chronic conditions. I think the thing is, it takes a long time to socialise the role, so I would say it took us 5 years to get those navigators accepted by the primary healthcare workforce on the West Coast. If I was to go back there now and go, oh, we're pulling the navigators, you're not going to have them anymore, there would be an outcry just because of the work that they actually undertake. Who wants to train to be a GP or a nurse to do logistical tasks like arranging transport, etc.? They do a wonderful role, and I think in the future, we're not, I think Michael highlighted, we are not going to have enough doctors, we're not going to have enough nurses. We actually need to look at other workforces. So not just community health navigators, where I am in WA, the area I look after is 3 times the size of the state of Victoria. Why aren't we looking at birthing assistants again? Because we're not going to have enough midwives out on country. So we really need to look at this alternative workforce.
Great, thank you so much. Sharon, do you see an area that we should be prioritising?
So I think navigators have a multifaceted role. I think from what we know from the literature and our practice so far, they rarely do just one thing, you know. So while there is a focus on getting people to appointments post-hospitalisation and, you know, making sure that that coordination of care is done, I think the real beauty of the navigator is that they have that time to develop the relationship with their clients, and they have that time to also discern with their clients what's important to them, because health is not always the main priority for people. You know, often there's a lot of other things that are impacting on their life, and particularly with things like chronic conditions. You know, we know that as people age and they get more and more chronic conditions, they get more isolated at home. You know, their worlds become smaller. So I think the navigator has a really great opportunity to link those people with other things other than health that, you know, that can make a difference to their lives, really.
What about you, Anthony? What do you see as being a priority?
So I think everything that the colleagues have set up here is really important. But for me, the missing thing that we're talking about is the importance of patients and families' lived experience and the advocacy role that Michael hinted at. We heard when the Secretary of Health says that there were times in her family when they needed navigation. I think the message for all of us is that there will come a time in our lives when we will all need some help navigating the system. We may know it, but and the best we can hope for is that we in our professional roles working around health know one part of it really well. So we will all need that navigation. And I think when we hear about the people's experiences of poor navigation, and I want to thank and acknowledge the consumers and patients and families who are sharing their story today. I think that needs to drive also what's important and how we plan navigation services and bringing that lived experience into the planning and how it's delivered. And again, Michael reported that I think the Medicare Review Task Force pointed at the importance of involving consumers and family and lived experience in that design process. And we've heard a lot about how navigators really make things easier, yes, for patients, but also, you know, for different aspects of the service and people who work in services. But I think having a navigator with you and somebody who may not necessarily be working with your service, there's someone there who can advocate for you, who knows the questions to ask that you may not know because it's your first time there, or because, you know, we don't know what we don't know about a complex system. And just by being there can actually challenge some of that unkindness that's built into the system. Susan again reminded us of the importance of kindness. And I think the flip side is sometimes busy people in busy systems, you know, can be terribly unkind to each other. And I think having somebody there to challenge that, to be there for the patient and to help the family is a really important area of advocacy. And we need to build more opportunities for independent advocacy into our health services, and navigators also can play that role.
And given, just continuing on from what you're talking about there, if they're playing, you know, this advocacy role, bringing some kindness into the process, what does this mean for the scope of the role? How does it impact other healthcare workers?
So, I mean, advocacy obviously means different things for different people, but just, you know, in terms of, and I'm not sure if I quite understand the question. I don't know if it expands the scope of the role a lot, but it's somebody who's there to make sure that the patient, if we're truly patient-centred, then we need to make sure that the patient and the family, you know, is getting the best experience. So if there's somebody whose role there is to help make sure the people are getting the service they need in the way that they need it in a timely manner, then just helping make that happen is a form of advocacy. So sometimes it might be quite explicit and challenging, you know, what people are being told, or challenging the way they're being told it, and otherwise it just might be the way that, you know, a good navigator works is, you know, being that advocate and making sure people get what they need when they need it.
Sharon, do you have any views on, you know, what the role, what the scope of the community health navigator should be, and how they interact with other health workers?
So I think it's not good to look at it as a separate role, and I mean, I think they're not there to replace other workers. And I think is that all right?
I think so. Yeah, so you're saying it's not to view it as a separate role?
No, not to look at it as a separate role, but rather a complementary role to everything else that is there. And I think you know, it's really important that everybody is kind of able to collaborate around the difference within their roles. Sorry, what was the rest of your question?
It was pretty much just asking how they work with other established roles within the health system. Is the potential for there being any tension?
Yeah. So I can only really talk about our experience with the Czech trial, but it did create some tension. I mean, we were putting a non-clinical role into a multidisciplinary team, and it did create some tension because I think people just didn't really understand what the role was meant to do. And as we've already heard, you know, multidisciplinary teams, they do tend to work in a very siloed way. They have their ideas about what is, you know, particular roles of particular disciplines, and that's kind of what they adhere to. And I think there was some tension, and I feel like that was changing over time. And Fiona has mentioned that, you know, in her work that it's taken 5 years, and I think you know, the acceptance comes with time, and I think, you know, people in multidisciplinary teams can really see the value of these roles, given the time and given the different time, you know, the amount of time that they work together. Having said that, though, I think a lot of there is a lot of focus. Well, I think it's dependent. Actually, I think it's quite dependent on who you have working in those roles and who you have working in those teams. And obviously, you've got to have people who are very accepting and prepared to, you know, embark on new things.
Luann, I see you nodding at the end there. Do you have a view on, what the how the roles can, if there's any possible tension about these roles working together?
I think, as Sharon said, there's always tension when you introduce a new role. There was a lot of tension when we introduced Shane, I remember. Oh, the role, not Shane.
Shane's great.
But slowly over time, once people understood why we had introduced the role and how it was supposed to work with the other role workers, Aboriginal health workers, the chronic care team, etc., it slowly was more accepted. And once you proved yourself too, with the NGOs, with a whole range of, and with the community especially, it was more accepting. But there's always tension. There's tension between medical and non-medical. You're stepping on my toes here, or what is your scope of practice, and really should we be taking the risk? I think that was a major concern when we talked about the extend workers, and it became more of a nursing model, and it was assistance in nursing rather than what we had aimed to do, which was a non-medical layperson to be reaching out. So you just have to be careful. Once we in health get our tentacles into things, we tend to change things to suit what our current teams are doing or what we're funded for, etc. So as Susan said, we've got to be brave and we've got to be doing things that are sort of outside of our normal thinking for roles. But yes, sometimes tension's good too. Yeah.
Anthony, can I get you to jump in there?
Sure, and I think, being involved in that project, I found those tensions fascinating in how they played out with the clinical colleagues. But I think that point about being brave and thinking in new ways, I don't think we always need to think that navigators need to necessarily be placed within clinical services. Sure, there's a role. I don't think there's one right way to do this. And I don't know if any of the colleagues from Positive Life are here at the moment. I think they might be joining us after lunch. Over here? Oh, hi Priscilla. Positive Life New South Wales is the consumer group for people living with HIV in New South Wales, and they run this amazing peer navigator service. So it's people and peers from that diagnostic community who have the understanding of what it's like to receive the multiple services that people need in and outside of healthcare, and have built up from amongst their membership these peer navigators. So I think that's an amazing example of where we can have really strong and effective navigation that's not sitting in a clinical service. We saw the partnership with the community centre, and we also know that there are people who have roles in community organisations. They might be family support workers or youth workers, social workers sitting outside of health, who also play out that role of sort of connecting people up and navigating. So effective navigation of health services doesn't always need to come from clinical services.
Fiona, what were some of your experiences in this area when it came to, just those really, at that very practical level, how the roles intersect and interact with each other?
So I'm going to talk about it in terms of the team itself.
Yeah.
So obviously, like over here in Australia, you've got Aboriginal health workers. When I pulled the team together, I thought, what were the skills we really wanted? So I know a lot of the vulnerable people in the rural area had connections with the judicial system. So we looked at someone who was a JP, who knew how to navigate the judicial system, and turned out to be very important. We obviously had a Māori navigator, we had a navigator who had lived experience of a disability, and we had a navigator who had lived experience of cancer, because remember, they started out as cancer navigators. But how they work together, so Reefton is a small inland town. It's the only inland town on the west coast. And there was a Māori lady who was dying, but her whānau, her family, were coming from the North Island. So the Maori navigator tended to her spiritual and her psychological needs because like Aboriginal people, Maori have a very strong spiritual belief system. But then one of the other navigators was able to go to the Red Cross and sort out the mattresses, the blankets, do the practical things that were going to enable her family to stay with her in her home until she passed. So I think, you know, you've got Aboriginal health workers, you might have community navigators, and there could be tensions, but they can complement each other really, really well. And I think we need to focus on strengths and not deficits.
So Bush, hearing all of this, how does that marry with what you've been seeing?
Yeah, I think I also agree with what Sharon and Luan already mentioned, that new role always associated with new problems, new understanding, new things. But I don't really like to talk it or present it as a tension rather than an ambiguity in the definition of the role. So once the time passes, the ambiguity becomes clearer, and the role definitions becomes also clearer, and then people come to understand what the specific role as navigator is going to play and how this is differ from other members in the health team, such as nurses, social worker, physicians. So, but this won't come in a day, and a lot of effort is required. For example, before coming to Australia, I was working in BRAC in Bangladesh, which is the largest NGO in the world, and they have mammoth community health workers. We had around 80,000 community health workers working throughout the country. And in the start of this, in 1970s or 80s, when this was sort of initiated, I didn't born obviously by then, but then I have learned from the literature and all that most of the people said, what is this now? What they're going to do? They're doctors. But after 30 years or so, now in villages of rural Bangladesh, they are accepted as a community health workers. So there is no definition, ambiguity, or anything, and there is no tension in their roles. So this, Michael has also mentioned about community health workers in USA. The thing that we have seen today is a long advocacy of many people, many organizations, including Public Health Association of America. So I think lot of advocacy is required to make the people understand what is the clear role definition of community health navigators, how they differ from others in the health teams. And I believe, like, for example, Public Health Association of Australia can take a lead role as well in advocate and disseminate these informations in throughout this landscape. And then once everyone is aware of the role definition, ambiguity will be removed, and there will be no tension among different health team members, and they can work complementary together, improving in health outcomes of all people they serve.
I want to talk about some of the benefits now, and I'm hoping that this is the exciting part of it. We've already had Fiona talking about how it gets you inside people's homes, and this is something that, you know, that wouldn't usually happen. So Bush, what do you think are some of the benefits that we may not be aware of?
I think, as I have started with the discussions, that we are still focusing only on few aspects of our navigations. There are a lot of spaces where navigations need to, for example, when we are doing the review for sort of exploring the role of navigators in chronic disease management, we found most of the research was improving adherence to screening for cancers. So which has not been appropriately used in our context. So as I said, like there is a lot things to be done. We are still in the early phase of the healthcare navigations if we compare to that of USA or Canada, where navigator has been widely used since 1990s when this had been introduced. So as similar countries, similar sort of health system difficulties and inequality, equity in accessing preventive or treatment services for chronic disease in Australia, that of US and Canada, there are a lot of avenues, especially is preventive care. I see that navigators can be very useful. And alongside that, that improving access to healthcare, social prescription, and these navigators should be adequately used in the preventive care at the community settings, because we can say that we have the best, one of the best health services, health system in the world, but unless and until it is accessible for those who need most, we cannot certainly say that, okay, we are doing the best. So we are at the edge of the community at this moment in terms of providing the healthcare services. We need to invade the community. So, and to do that, I believe health navigators can play a very, very crucial role, because they are living in the community. So they are essentially part of the community, and community engagement, empowerment, and activation. These three things can happen through these community health navigators, and only then this pathway of health service access can be cleared up.
Should we be, given that that we're still in the early stages here compared to some of the countries that you've seen, what are the things that we need to keep in mind right now as far as assessing change goes?
Yeah, I think as I said, like we need to be aware of that we are at the early stage of this development process, and that we need to do a lot of advocacy. As I said, the RSCGP Michael is there, so probably other institutions like those who are community-based organizations involved in this approach, they need to be make aware of these initiatives. Still, for example, when I was working in the primary care settings, one of the big role has been played by George Tang, Dr. George Tang, who is here. He has been a great advocate for us, and his support has been instrumental to have this done in such an effective way. So we need more people like this who will be an advocate for the work, who will make the clinical people aware of these non-clinical services, which can help the people better access to the services, which is at this moment is missing. So if we can say that, okay, you have this service available, it's not make it accessible for those who have language difficulties, who have cultural differences, who don't understand the Australian health system much. For example, I am from Bangladesh. When I came in Australia, I thought, okay, what is this primary care? What this GP means actually? So I used to go to hospital. So, but here I then start learning. I said, okay, the gatekeeper, the word gatekeeper of health system is GP. I have no idea. And those who came in 1970s, 80s in Australia as an immigrant, who are middle-aged, they have very little idea of the Australian health system, this ever complex health system. And as Michael mentioned, it's a fragmented. It's very hard to perceive actually from where to go where. So to make this ever complex pathway clearer, I mean, we need to do a lot of advocacy, and it works. We have seen this works, and it has been a cost-effective ways to do that as well. So it works, but a lot of the people are not aware of what exact role the navigators could play, and where they should be involved, what are the spaces, what are the pathways that we should have them. So I think it is really important that is advocacy piece is going on from every level of the intervention.
Sharon, in your view, what are some of the benefits here?
Multiple benefits, I think, and if you look at the literature, you know, and I've got a list here of, you know, there's multiple benefits around access and, you know, healthcare utilisation and, you know, better coordination of care and all of those things. One of the things that that we identified when we were doing our study was that from within the healthcare team, navigators were really valuable about picking up patients who would otherwise have just been left. Like, even though the healthcare team had a remit to follow up patients, they rarely were able to do it to the amount or to the efficiency that they wanted. So, you know, the healthcare professionals were finding that having the navigator just gave them that opportunity to work more around their own role, because the navigator would go out and do the initial assessment and be able to identify, you know, what was needed, and a lot of that admin stuff, because there's a lot of admin that goes with, you know, getting people linked in with services. You know, if you want to make a referral to aged care, there's a whole heap of, you know, paperwork that has to be filled in and that kind of thing. I think that's probably...
Yeah, and Anthony, from a consumer perspective, you know, what we're hearing a lot about admin. Is that the thing that they've got in their sites?
Well, I mean, people are pleased when, you know, it reduces sort of the life admin, the burden that some of the burdens Michael was talking about, of course. But I think, I mean, the main thing, of course, is improved patient and family experiences and outcomes. And the evidence is pretty clear that it does that. But I also think, as I said before, there is so much navigation that is happening outside of clinical services. Families and patients are becoming skilled navigators because they have to. And we also, as I said before, there are people sitting in community services who have like a lot of local knowledge about how to help people sort of move from one service to another to get what they need. So I think one of the advantages of sort of talking about care navigators and having sort of navigation is we're actually starting to value navigation as a skill that's needed for effective healthcare. So I think the valuing of that and the involvement of people who have that experience in designing what better navigation looks like. I think it's moving the dial a little bit from the way that I think sadly traditionally people have seen patients and communities as problems and people who have problems to actually being part of the solution. So moving to that strength-based, asset-based sort of approach to patients and community.
Before we move on to the challenges, to the real experience that we have at the end of the panel there with Joanne and Fiona. Fiona, you've already mentioned some of the benefits. Are there other things that we're missing that you want this room to know that are real benefits from community health navigators?
So I think I'm not going to answer the question because there's a couple of other things I want to say. Because I think
For sure.
I think everyone's answered the question, and Michael gave a good summary of the benefits earlier. I've got a question: is why do we need navigation? We need navigation because we live in a neoliberal society that expects people to be self-responsible for their own care. And there's going to be some people who are just never going to be able to achieve that, and they're going to continually need that support. So while we've got navigators, and that's great, and number one supporter, it doesn't mean we can stop looking at the system and how to fix it. We absolutely have got to. And you know, living in WA now and going out on country, how the hell Australia got number one in equity? I mean, it's beyond me. Yeah, so I mean, and the other thing that Anthony was saying about valuing is really important if you're employing navigators, that you actually value them. You don't just give professional development to your traditionally trained staff. You find out what areas the navigators are interested in and you support them to extend their skills. I can't, you know, the system's been broken for a long time. It's not going to be fixed overnight. So we are going to really need these people, and we're going to need them to work what is the jargon at the moment to top a scope as well.
Is it frustrating to be working on something like community health navigators when you've sort of got your eye on the reason why you need them in the first place?
I think, as you mentioned earlier about the report about, you know, the focus on prevention and promotion. Gee, that jargon's been around. I don't know how long that jargon's been around, but you know, Michael's partialist colleagues down the road in the hospital unfortunately have a really strong voice. We all know, we've known since Barbara Starfield's work, the power of good primary community care. And we're still working to an acute system. I have, as a director of a university department of rural health, I take health science students from universities, and they come up to Kalgoorlie and elsewhere in the district for experience. I hate to say that in the nursing degree, they get 2 weeks in primary care. And they are, they have a module that's called complex care. They could easily be based in primary care, but they're wanting to be based in the HDU, in the regional hospital. So, in academic institutions, we also need to look at the health professionals that we're training, and are they going to be able to meet the needs of the population and the communities? And the other thing is with the services, what are they designed around? They're designed around health professionals. That we don't go into a community and say, what service does this community need? And we'll build that service from there. We go, oh, yeah, we've got a lot of specialists, we'll build a hospital and they'll come, hey ho. It is frustrating that the very fact we need community health navigators is frustrating.
Luann, any thoughts on the benefits, the challenges, or any other thoughts that you want to share on this?
I'll go back to the benefits. And the beauty of having a mobile phone, someone's just reminded me that I've forgotten to mention the wonderful cultural support team, which was, once again, the idea of the Centre for Primary Healthcare and Equity that started the thinking about cultural support workers. And then we've got the Central Eastern Sydney Primary Health Network, who funded the start of the thinking of these cultural support workers, Southeastern Sydney and us, and Herdu, of course. The partnership is just amazing. Now, this is 142 people, head count, 2 FTE, for those who are counting those numbers out there. I had to remind the CE the other day, it's only 2 FTE, but this is 145 people that are from all different backgrounds. So we have 149 different languages within Sydney Local Health District, which is reflective of all the other LHDs that are here at the moment. And they go out and work with the community, and so it's developing that bridge between those different communities and also with health. But the major spin-off I'm seeing too is our partnership with other organisations, and Shane's really worked, and Counterpoint, we've got a really good, strong relationship, and I think Shane has assisted with that, so that worker has brought us closer together, and I think the workers do that, not only bring the community closer and trusting health more, but it's also us as workers are learning to work with NGOs and see the benefits of other organisations and other government agencies as well. So all of those as part of the team, a very important part of the team, I think that's the spin-off. And so we're embedding all of these workers, our peer workers, our Aboriginal cultural support team, a whole range of those different workers, we're embedding them within the system. And I agree, where they're best located, the other workers, the community health navigators, is yet to be seen. I was just speaking very quickly with Health. Is Health Justice here today? Any reps from Health Justice? I was just speaking very quickly to a couple of people the other day, because we have Redfern Legal Centre and Marrickville Legal Centre embedded within the system, but they were talking about embedding social workers in some of the legal practices, and I mentioned at the time, had they thought about community health navigators? So I mentioned Mark and Liz's name to them, but it's that thinking of where else can they add value, and intellectual disability was the other focus of the topic that came up, because there's the Centre of Excellence at the University of New South Wales that's got a national role as well, but it's always that thinking of who else can we talk to where there's another role where we can have these very valued community people that have grown from the community, haven't they? So yeah, that was, I was thinking that's a spin-off that we don't always note.
And just before we open up to questions, just to get a bit of an idea of what you think some of the challenges might be in this area that we haven't already covered. So if anyone's got any thoughts, feel free to jump in.
I think one of the big challenges, if we sort of want navigators to part of our healthcare team is to have their accreditation as a health workforce. So the training and accredited as a health workforce is really important. I know Rebecca is doing very good work in this space. So we need to have this established through, and there need to some community organization or any other organization who need to inherit the training program as well. So we have been doing this. We developed a training program, Mark, Liz, and we developed a training program, but this is more on an ad hoc basis to our PhD work. But university is not the place where this training on a larger scale could happen. So we need to find a host for the training program as well as the accredited training program as well to make them as a established accredited health workforce if we want them to the health team. So this is one challenge that need to be addressed, and also the continued funding. So we have been doing small works, but we need to do this in a larger scale. We need to see the effectiveness of these interventions in terms of the realized benefits that we are talking about. So so we are still in the earlier phase, but we need to do more larger scale initiatives to prove it really works in an experimental design or so. So these two things are also really important and a big challenge for the next steps as well.
Sharon.
So this goes on from the training, but I think it's really important that if we have community health workers, that they have recognition within the system. And so to do that, we need training, but we need qualifications, and we also need career pathways for them. And the other challenge that I'd like to say, just from a researcher point of view, is that we need some consistency, and I think Trish mentioned this before, just some consistency around the way that we record our research, because if you read 100 Community Health Navigator articles, you'll get 100 different kind of processes, and you never really know exactly what's happened. So some consistency around, how they were trained, what they did, what their roles were, the problems that were faced. I think that's really important.
Anthony, did you have any views on challenges?
Yes, of course. I suppose so. As I said, we were involved in this research project, and before working in Health Consumers New South Wales, I have a research background, and I just want to say, with respect, I think we have a lot of research and evidence on the effectiveness of health navigators. Of course, there's opportunities for more research, but let's actually find ways to get more navigators on the ground. And I think that clear problem around, what are the funding solutions? What are the funding streams? It's not, let's hope the Medicare changes and review can bring in one funding stream, but that's not enough. And I'm also not that concerned about that diversity. I know it's frustrating when we're reading different reviews from different areas and different definitions. But as I said before, I don't believe there's one right way to do this, and let 1,000 flowers bloom. So I just think we need to really have a hard look at the funding structures, because we've got so much evidence, and at the end of the pilots or the research studies, we've gone back to the services and the people who've trialled it, and there just hasn't been a way that they can say, oh great, yeah, we're going to support this, or we'll embed it in our current sort of systems.
You're getting applause there. And Fiona, any final thoughts about the challenges? It might just need to be nice and close.
I think
Yeah, that's it.
some of the stuff we don't know is around caseload for navigators. What caseload can they carry, and what's the mix of that caseload, complex and simple. What I do know is that the navigators really care about their community, so they actually take a lot on. They will actually work more hours than they're paid. So we know that our health professional workforce is burning out. We really need to have an eye on our navigators and have good support around them. So that, I mean, that is definitely a concern. So caseload, the mental well-being of our navigators, and then be careful for what you wish for in terms of how you're going to measure the success of the navigators. Because quite often they are dealing with people with multimorbidity, and we know the trajectory is downwards. So are we going to expect that to be fewer ED visits, fewer hospitalizations? You know, let's look at what matters to the people that they care for and how the navigators themselves would determine success. So we really need to look at the metrics very carefully.
Before we go to questions, if we can finish with you, Luann, any final thoughts or any thoughts about challenges in this area?
And I've gone blank now. The challenges were how do we measure what you're actually doing? And that's the challenge of embedding them within a health system, which is based on activity. Your success is based on activity, and the activity is paid for by the government. So how do we measure that activity? Because they're non-clinical and they don't sit under a particular award classification. So that's another issue that needs to, I think Tish is here this afternoon. Are you here, Tish? No. Tish is here this afternoon, but it's a workforce issue if they're embedded within health. But that's a question I've been asked all the time. What's the national weighted activity you can put against the work they're doing? And it's very challenging to do that. And as you said, it's getting more complex. I mean, the people that they're having to see, it's not easy work. So we have to be very careful we're not pushing people into an area that they won't be able to cope with, or that we're not providing enough backup and support. We have workers that were doing ED to community, which is another integrated care project, or not project, model of care by the ministry that we're all doing at the moment, but those people burn out very quickly, having to look after very complex people that are commonly coming to ED for many tricky issues, social and physical. So it's the measuring and how we prove that value back to government. That's going to be another challenge. Yeah.
Absolutely. Look, thank you so much to all of you. We're going to open up to any questions from the audience. If you pop your hand up, and Tony will run over to you with one of these mics.
Trish Davidson from UNSW, and I hate to be the person who starts with a comment, not a question. They're the worst, but that's me. Firstly, thanks to the panel. It was very illuminating. But it's just a reflection that we have to embrace the education dimension of this. And I think thinking about community health navigators within the Australian qualifications framework, where there's scaffolding for career progression, is really important. And I'm just wondering, with Barney Glover currently as the head of Jobs and Skills Australia, and the importance of the care economy, that's another language, you know, from another dimension, that there might not be some scope for advancing the cause. But more thanks to the panel.
So I think whether it sits within universities, but we've got the opportunity now of micro-credentialing or short-form learning, whatever you want to call it. And I think for communities, that's really great, because someone might start by doing a micro-credential in healthcare navigation, but they might then go, well, maybe I will become a nurse or something. And so you could start to get a stream of people that you might not necessarily have got coming to be part of the health workforce. So I think it's a real opportunity. And what I see in the region I work in is a missed opportunity to engage with mature students that, you know, we're entering the era of lifelong learning, and, you know, people do change career. So I think there's this whole micro-credentialing offers opportunity for another pipeline into the health workforce.
I agree Absolutely. There was no suggestion that universities be the place, but the Australian Qualifications Framework scaffolds from the vet sector, the private sector, and it just means that exactly the point that training is seen as part of a cumulative experience. And, you know, I agree absolutely. And universities are probably not the best place, but recognising that cumulative learning is really important.
Hi everyone, and I also just wanted to thank the panel for an amazing discussion. My name is Rebecca Jessup. I'm located in Victoria, and hot off the press, we actually have been working, we had a workforce training and innovation grant to develop a TAFE qualification for navigators, so it was contextualising an existing qualification. We did a huge amount of co-design work with diverse communities, clinicians, patients with lived experience, and managers and academics, some people who actually employed navigators. And we now have a 12 module course that is available. I think at the moment it's on the TAFE Victoria website. So we were just talking today with some of the New South Wales colleagues about how we can get it into the New South Wales framework, but it is accredited. It also includes 33 micro-credentials, so people can pick up components of it if they don't want to do the whole course. And we're hoping this might actually help us address some of the issues we have with activity-based funding and recognising the skills, and perhaps being able to pitch for some NWOW funded positions, certainly in the hospital system, which is where I originate and where we've had major challenges keeping some magnificent individuals employed with very short-term funding arrangements. So yeah, happy to talk to anyone who wants to hear more about that later. But we have a poster out in the foyer as well, and thank you for the invitation to come today.
Thank you. Any other questions or comments for the panel? And if you want a specific panel member to address it, just direct it at them.
Yes, I guess one of the opportunities that are there with people that are working in community in the health space is how you actually use that lived experience at the local level to feed back into some systemic changes within the way in which health or all other bureaucracies work. You have a situation where you have very siloed situations and quite often successful navigators actually bend the rules to be able to get people through the system, where if we could actually do some changes to the systems, then we could actually make it easier for a lot of other people. So I guess it's how do you listen to people on the ground, and how does that inform systemic change I'm interested in?
So I think that's such an important point, an important question. And while we know health is very siloed, the thing that we often forget is that the patients and families are the only people in the system who move through the entire system. Everybody else sort of stays in their silo. And I think we do already have great examples of involving people with lived experience, patients, carers, families in service design. We've got great work that's happening within different parts of the university sector as well. And so there's lessons we can learn about how to do it. And in terms of, you know, the mechanisms and methodologies, they're all out there. But I think we're in a great place to join together. And in this room, there are people who are patient and consumer representatives who sit with hospital committees, CHN committees, who are already involved in designing sort of systems and services. The infrastructure, the knowledge, and you know the ways to do it are already there. We just need to bring it across more into this field. I mean, I don't know if anyone else has reflections on that.
I think, yeah. Yeah, I really agree to what Anthony said as well, to including rather a collective approach. I would say still now we are working in an individualistic approach, but chronic disease management, multimorbidity doesn't really work in an individualistic approach, especially when we talk about the multicultural populations group, um, because decision making in terms of healthcare decision makings not always made by the patient itself, especially in the chronic disease, especially in the multicultural population groups. So as I said earlier, it's really important to invade this final layer of the community, go beyond this layer to the itself in the community, and engage the community in a collective approach is absolutely important. And the lived experience person and their surrounding peer model can be really impactful in this approach.
Maybe one last quick question. Yeah.
As someone who worked in the tertiary rehabilitation area as a counselling psychologist and also volunteer in the justice health sort of advocacy area, I'm very aware that we are facing so many problems with silos and gaps, and the current Bondi Junction coronial inquiry is absolutely exposing those for mental health. There could be nothing more complex than navigating mental health services, and we see the dire failure of GPs, psychiatrists, the whole interplay. And this is a terrible reminder, and it's something we need to face, that we have to change. Now, on the writing on the back of a few of those last comments, this is like an interesting to come to this point to say, I can't see how the system is actually going to change, justice or health systems, unless we break down those silos. And that means outside New South Wales Health, ensuring that we develop community grassroots programs, and especially for mental health, which is our top key issue. There is nothing more complicated than that. And then when we see the dire, tragic consequences of it, we should turn around and point the finger of blame at ourselves for the siloing that happens and the lack of local grassroots commit. I want to see how we can develop that aspect, because non-clinical support alongside as an auxiliary to clinical care, I see is the only way we're doing it, where we can already see how the mental health system has resisted change. So I'd like anyone who'd like to comment about that, because we have a real chance for change, see?
Anne's area.
Any responses from the panel at all?
I think, yeah, it's really, really complex, isn't it? And we also know, like, if we do get that grassroots support, that'll end up with longer term change rather than a top down. But I think in terms of clinical, where we need to move to, and there is resistance to this, but I cringe when I hear the term multidisciplinary. We need to start to be interdisciplinary within the clinical area as well. The change won't happen because of resistance within certain sectors or professional groups. Yeah. You know, so I think it's coming, because it's going to be mandated within health professional accreditation that they must have interprofessional experience to graduate. It's not there yet, but it is going to come. So that will come, but you know, it is about as we've all.
Our systems aren't multidisciplinary. You know, when I look at the hierarchy of decision making, that's not multidisciplinary. Having a mental health nurse follow the instructions of a psychiatrist or a registrar is not multidisciplinary.
It's not.
And so we're kidding ourselves. What we need to do is actually ensure that our health systems enable community controlled, community grassroots managed outside of the health system